Good evening, everybody. Today I'll be talking about liver transplantation in children, hepatological perspective. So, giving a broad background to my lecture today, these are the two main key areas I will be talking today. Liver transplantation in children itself is a broad topic. So, I thought I would give you an overview and key facts about liver transplantation in children. That would be the bulk of the talk today. And towards the latter part, I will be sharing the current program, challenges, and what would be the way forward and the future. Giving a bit of a background, liver transplantation in children. So we all know liver is an essential organ without which the death is inevitable. And when the liver fails, there is no other substitute. And liver transplantation is the life-saving procedure for children with many liver diseases meeting the criteria to have a liver transplant. One important fact to highlight is, in contrast to kidney disease and renal transplantation, if I'm correct, there is no substitute to bridge or a method to buy time when the liver fails. No other option other than liver transplantation can be offered to children with liver diseases when they are in the end-stage liver disease, or maybe with acute liver failure, which cannot be rescued with medical management. Though it sounds quite naive and novel to the developing world, liver transplantation is the standard of care with excellent short-term and long-term outcomes, and it has become the standard of care, and it is being given available to everybody in the West compared to developing world. So having that background in our mind, if you look at the picture on the right side of the screen, you can see a child with liver disease with all the features of chronic liver disease as well as the liver failure. You can see the transition of life which has been made with the liver transplant in the second picture, where the child looks quite happy and the abdomen is not distended and possibly has thrived very well with the time. So this transition together with liver transplantation looks quite interesting, and it obviously gives a transition and transformation of the life. However, is it that straightforward? It is not. It is actually a long road and a long journey. Going through the liver transplantation for the healthcare staff who are involved with it, as well as for the parents, children, parents, and their families, is quite a long road. So let's look at this long road in a systematic manner. How would you select a child for transplant? What would be the procedure? And what are the factors which you should keep in mind when you think about post-liver transplant period? Let's start from the dark end. Disease burden. So sometimes we question ourselves, is there a disease burden related to liver disease in children? Because we commonly know the disease burden related to adults, but the disease burden related to children is often overlooked. If you look at these pictures, all these children were identified as candidates for liver transplantation, and they are at various ages. There are infants, young children, older children, adolescents, in various status of the liver disease as well as liver status. Some of them have grown quite normally, it looks like, but some of them have severe nutritional deficiencies. And some might look just near normal, though they are having significant liver dysfunction in various means. So the disease burden exists. If we look at the data, we analyzed all the referrals which took place to our unit CNCLD between 1st of June 2020 to 30th of May 2021. There were 101 children who were referred to the unit during this period. And of them, there were 22 children were identified as needing a liver transplant. They were identified as liver transplant candidates. And you could appreciate the biliary atresia is constituting half of the population of liver transplant candidates in childhood. The data are quite similar in other countries as well, and sometimes it's even more. In certain units, in their publications, they have highlighted that even up to 70 to 75% of the children needing a liver transplant are biliary atresia. So it's very important. So having the disease burden in mind, I'll go through three main key areas related to liver transplantation in children. I'll discuss facts about pre-transplantation. What are the indications? What are the contraindications? When would we say yes and when would we say no to a liver transplant in a child? Very briefly about transplant surgery, just to give you the context and linking pre and post-transplant period. And subsequently about post-transplant care. First, we shall look at pre-transplantation. What are the common primary diseases in childhood which would require liver transplantation? As I have mentioned earlier, biliary atresia is the main disease. If you see two children needing liver transplant, one would have biliary atresia. And the challenge in this population is actually they are quite young. 80%, 70 to 80% of the children needing liver transplant due to biliary atresia are less than 2 years and less than 7 kilos. So it's quite challenging to the surgical team and medical team to look after these young children with biliary atresia. And the other important point to highlight about biliary atresia is its relationship to the Kasai-portoenterostomy. We all know Kasai is very, very useful in delaying liver transplantation. I highlight the word delaying because it's not the cure for biliary atresia. So sometimes it's very important to focus on the post-Kasai care and to look whether the Kasai had really been successful when you look after these children, because they constituted the bigger portion of the candidates for liver transplant. Genetic and metabolic liver diseases. This has become actually a very interesting indication for liver transplant in children. If I am to categorize metabolic disorders or metabolic liver diseases in children, I see it in two main components actually. One is metabolic disease would cause parenchymal liver damage and finally cause liver synthetic dysfunction. For example, Wilson disease, tyrosinemia, galactosemia, all these disorders can cause significant impairment of liver functions and liver synthetic functions due to parenchymal damage. On the other hand, there is a group of metabolic disorders like Krippel-Najjar, urea cycle disorders, maple syrup urine disease, where you will really not see a parenchymal damage. However, they will have metabolic crisis and impairment of quality of life due to the absence or deficiency of the enzyme, which is mainly located in the liver. So in both these categories, liver transplantation becomes the ultimate cure. What about malignancies? There are unique type of malignancies which occur in children like hepatoblastoma, hepatocellular carcinoma, Langerhans cell histiocytosis, hemangioendothelioma, and so on. When these malignancies involve the entire liver, all the segments, both lobes, then there is no other option other than replacing this liver with a new liver. Basically, when the primary tumor is not resectable. Autoimmune liver disease, a well-recognized indication for liver transplantation in children. All the types of autoimmune liver disease can cause liver damage and finally synthetic dysfunction requiring a liver transplant. What about infections? The common infections which causes significant liver damage would be hepatitis B, C, cytomegaloviral infection, as well as enteroviral infection. We really don't diagnose enteroviral infections in the developing world due to the absence of resources to diagnose. However, in the Western world and developed world, they do have diagnostic methods like enteroviral PCR, where this infection is increasingly being diagnosed and considered as an indication for liver transplantation. One other important disease I wanted to highlight was gestational alloimmune liver disease, which was earlier known as neonatal hemochromatosis. This is a unique disease entity which occurs in neonates due to alloimmune background. And the pediatric team would know that it would occur in families. It would commonly present as acute liver failure in the newborn. And most of the time, the other therapeutic modalities like plasma exchange and immunoglobulins would not work, would not be able to rescue the liver, where the liver transplantation being the ultimate resort of management. Moving to intestinal failure associated liver disease, again common in the West compared to developing countries, where due to the development of perinatal care, we see a lot of extreme preterm babies surviving with short gut syndrome, as well as developing the liver disease related to their intestinal. So this category of people also would require liver transplantation if their synthetic functions fail, or if there are other indications which I will discuss. Budd-Chiari syndrome, again a straightforward indication for liver transplantation. Acute liver failure in neonates and children of any cause. I wanted to highlight this neonates group because most of the time the neonatal acute liver failure is not really diagnosed or put into the platform. Because we take it as coagulopathy, sometimes we just tell multi-organ dysfunction, sometimes most of the metabolic disorders and the unique category of disorders which present as acute liver failure in newborn are being missed. So acute liver failure of any cause where you cannot rescue the child with medical management or supportive care would require liver transplantation. Drug-induced liver disease, again not an exception, might cause acute liver injury or might cause significant long-term liver dysfunction. And at the end, a word about combined organ transplantation like liver-kidney transplant, especially in primary hyperoxaluria type 1, liver small bowel transplant in short gut syndrome, as well as with intestinal failure associated liver disease, liver bone marrow transplant may be the way forward for children with immunodeficiencies, aplastic anemia and hepatitis, and thalassemia sometimes. Liver lung transplant for cystic fibrosis, and multivisceral transplant, which are happening in the Western world. The main indications are being dysmotility syndromes, where they have gut dysmotility, requiring a small bowel transplant, and at the same time, they have intestinal failure associated liver disease, requiring liver transplant, and they would require stomach as part of the gut, which would make it multivisceral compared to a liver small bowel combined transplant. So all these types would require liver transplantation as the last resort of management. If you have identified those primary etiologies, what would be the timing? That is very important. The diseases I have talked about, we would not require a transplant at the beginning sometimes. We really need to plan the correct timing and indications. So let's look at what would be the indications for a liver transplant in a child who's known to have a liver disease. The straightforward indication would be decline in liver synthetic functions. Prothrombin, thyme, and albumin, it is very straightforward. And if you see this child, it's very obvious this child is having all the features of chronic liver disease. And child is in end-stage liver disease. Unresectable malignancies, there is no timing. You really have to go for liver transplant. If it is unresectable, you can't wait. What about life-threatening recurrent cholecystitis? This would become important, especially in the context where you have normal or preserved liver synthetic functions, but a child is having recurrent episodes of life-threatening cholangitis. This is a common scenario in children with biliary atresia, where they get collection of bile or pooling of bile, which are known as bilomas. And they get recurrent life-threatening episodes of cholangitis requiring ICU care, near escape of death. So in these type of circumstances, despite the synthetic functions being normal, we have to offer liver transplantation as a treatment modality. Uncontrollable portal hypertension. We all know chronic liver disease goes hand in hand with portal hypertension, and it can be controlled up to a large extent with the endoscopic program. However, in certain occasions, despite the child being on endoscopic program, if the portal hypertension is uncontrolled, child presents with recurrent episodes of bleeding, especially with fundal varices, you might need to consider liver transplantation despite the synthetic functions being normal. Hepatopulmonary syndrome, portopulmonary hypertension, it's again a challenging indication. If you look at this child, this lovely little girl, she had absolutely fine liver synthetic functions. However, unfortunately, she had very severe hepatopulmonary syndrome. By looking at her, we would not recognize her as a child who's needing liver transplant by the external appearance. She's walking, talking, looks well, there is no distended tummy. However, she has severe hepatopulmonary syndrome, which is not really in alignment with the other liver synthetic function. So it's very important to look at these individual indications when the situation is quite not straightforward. Refractory pruritus, especially in PFIC, progressive familial intrahepatic cholestasis, biliary atresia. So this child is having normal synthetic functions, however, having refractory pruritus to all the medications. There is no time that mother can recall the child or the family had been at a continuous sleep for about 1 hour. So it impairs the quality of life up to a greater extent where the ultimate cure is needed. Impaired growth and puberty and hepatic osteodystrophy. Recurrent fractures might be an indication. When it comes to metabolic disorders with preserved synthetic functions, frequent and severe metabolic crisis would warrant a liver transplantation. And all these indications would come into play where you have looked into contraindications. So let's look at the contraindications. What are the absolute contraindications for a liver transplantation in a child? Primary disease, it matters. Is this a disease which is transplantable? We always have to question. The diseases like Niemann-Pick type C, mitochondrial disease, which are inherently progressive and having multisystemic involvement, would preclude a liver transplant. And the other contraindications are quite straightforward: the irreversible, severe, or progressive neurological damage, or other organ dysfunction, disseminated malignancy, disseminated sepsis would be a contraindication. Extensive vascular thrombosis might put surgical challenges, because during the transplantation procedure, the surgical team have to connect all the vessels. And if there is extensive thrombosis, that might put a challenge and it might make the child untransplantable in the setup where the child is actually. Relative contraindications, limited vascular thrombosis, it depends on the expertise you have to operate. Localized sepsis, severe hepatopulmonary syndrome, severe portopulmonary hypertension. There are units and centers who have attempted to transplant these children, and there are very few cases which has resulted in success. However, it all depends on the expertise you have, whether you would like to perform a liver transplantation with this type of severe disease. Immunodeficiency is considered as a relative contraindication. However, with the availability of bone marrow transplantation, now it has become out of the list. Family circumstances out of the all most important, whether this family could survive the long journey of transplantation, might come into play in decision making. Age and the size. There is a very frequent question which is coming through, actually asking about the minimum weight and the age for the transplant. There is no limitation with the weight and the age. Only thing is the challenges to the surgical and the rest of the team due to the small body size and the related hemodynamics. So this is an example where the world's youngest liver transplant recipient meets her surgeon in the city. This was reported in the news in 2018, where this lovely lady was transplanted where she was day 5 old for gestational alloimmune liver disease. And she visits Chennai to see Prof. Mohammed Rela in 2018. And you can't recognize she has had a liver transplant if you look at her actually externally. So this is another story where 2.1 kilo weighing child was transplanted, again for gestational and liver disease. So all these stories will emphasize that there is no younger age limit or a weight limit. It all depends on the resources you have. A word about scoring systems. Another common question is about what is the use of scoring systems in pediatric practice when it comes to listing as well as predicting mortality. They are useful, but there are limitations which we have to understand as well. If you look at this modified King score, which is used to predict mortality in children with Wilson disease, it is actually very useful. And they use all these 5 parameters and put the score into place. And if the score is more than 11, it is said the urgent liver transplantation is needed and mortality is more than 95% without a liver transplant. So these are helpful for us to predict the mortality, especially for a disease which has got a treatment. If you look at all the diseases, liver diseases which happens in pediatric practice, only the Wilson disease and autoimmune liver disease has got disease modifying specific treatment modalities. All the others are supportive care other than liver transplantation. So it's quite challenging when you have a child with Wilson disease when to say yes and no for the transplantation. And this score is quite helpful for you to predict mortality without a transplantation. And what about the other scores? MELD, sodium, child score, PELT score. They are useful. They are objective and reproducible. When a team is discussing about a child, it's easy to put everybody on the picture when you talk about the scores. And they're reproducible, especially if you are writing into scientific evidence. However, we have to understand the limitations of these scores as well. If you concentrate on this picture and the brief message given in the picture, there had been 17% of the children in this cohort of 3,200 pediatric liver transplant candidates who fell into the growth failure gap, which was not detected through the PELT score. And they had waitlist mortality and they had post-transplant mortality as well. So we have to use these things by understanding their limitations, because especially when it comes to children growth, development, puberty, quality of life, all are very important. And they are not really coming into play in these scores. And the time on the waiting list is again not very much reflected. And it's not applicable for metabolic diseases where the liver synthetic functions would be normal actually, and for malignancies most of the time. So having talked about the disease burden, indications, contraindications, let's look at how will we assess a child for transplantation. We have gone through the diseases and indications, and now we feel this child would need a transplant. Then the child should be subjected to a transplant assessment. There are key areas in a transplant assessment which has got multiple assessments, MDT referrals, vaccination, and the counseling. Those are the key areas which I will discuss. In view of assessments, when we get a child referred for liver transplantation, firstly, we need to assess the liver disease. It's very important to understand the primary etiology of the disease. Because when it comes to post-transplant management, long-term care, and planning for the challenges and proposed actions, everything would matter sometimes with the underlying etiology. It's different the way you manage a child with biliary atresia post-transplant, the child you manage with autoimmune liver disease. And it's totally different to metabolic liver disease. So it's quite important that we confirm the primary etiology of the liver disease in this child. If I am to give another example, progressive familial intrahepatic cholestasis, it's very important to understand the type, because in type 1, you anticipate few other organ manifestations coming into play after transplantation. Once the liver is back in place, then only they develop intestinal manifestations. So it's quite important. And when it comes to confirmation, what I mean is genetic confirmation whenever possible. Because most of these disorders in childhood have got a genetic background. And there are known mutations which can be identified. So it's very important to confirm the primary etiology. What about the blood test? We do routine liver blood test to assess the synthetic functions, excretory function, and all these other related functions. And alpha-fetoprotein is quite important. Any child with chronic liver disease has got an added risk of developing malignancies and malignant nodules. And the risk is quite higher in tyrosinemia and PFIC type 2. So it's very important to look at the alpha-fetoprotein. And if that is raised, if there are focal nodules, then you have to extend your investigations further. Imaging is important, ultrasonography, to look at the liver, the vessels, as well as the other relevant parameters in relation to transplant assessment, and triple phase CT. This will be very helpful for the surgical team to plan their surgery as well. Understanding the anatomy and the intra-abdominal varices, whether there is thrombosis in the vessels, all these things would come into play. Optimization of the residual liver status. It's again of utmost importance. Because when we get a child today for liver transplantation, it won't happen tomorrow. So we have to optimize the child to be stable on the transplant waiting list. All the medical management, all the rescue measures will be put in place to stabilize this child's liver status. That is also part of the transplant assessment, I see. Assessment of other organ function is very important when it comes to kidneys and cardiac function, pulmonary function, because the child is going to go through a major surgery. It's very important to check the fitness, associated cardiac abnormalities and their implications, and kidney function. All these would come into play. Comorbidities and allergic history is quite important. Infectious screening. We do all these things when a child goes to a transplant assessment and they have clinical significance and relevance to the child and the child's management. Virology is important. Following the transplant, child will be put on immunosuppression, which would increase the risk of opportunistic infections, including EBV, CMV. So it's very important to understand the status of EBV, CMV prior to transplant, where you can plan your antiviral prophylaxis as well as the immunosuppression following transplant. Hepatotrophic viruses, we routinely have to check because they have an effect on liver. And also the infectious screening, MRSA, ESBL, VRE, CRE, all these are important. The colonization with these organisms would have an impact on the post-transplant antibiotic regimen. And if you find a child is colonized with MRSA, you can do some measures to decolonize them before the transplantation. As it would be very challenging if this child develops MRSA septicemia in the context of immunosuppression following liver transplant. So all these measures would take place during the transplant assessment. In our setup, doing MAN2 chest X-ray, and obviously in the current context of the pandemic, COVID-19 status, all are important. Dental assessment, it's very important. And we routinely do that for all transplant candidates, and we refer them for necessary management as well. I'll tell you one story. There was a child who was transplanted for a genetic disorder, which was PFIC, whom I have encountered during my overseas training. And this child was from Northern Ireland, and the transplant assessment was performed as a distant way. Usually we perform the transplant assessment in-house in Birmingham Children's Hospital. However, it was performed distantly because of the travel problems and all. Due to some reason, this child has not had a dental assessment. And this fact was escaped from the team. And then child came to Birmingham, there was a liver offer, and child had a transplant. And following transplant, in the post-transplant period, child had a severe sepsis related to dental abscess, and child had disseminated sepsis, had 2 months of ICU stay, simply triggered by dental abscess. So it's very important. That gave me a lesson how important the dental assessment and the management and maintaining good dental hygiene while being on the transplant waiting list. Nutritional assessment, it's very straightforward that we need a nutritionally optimized person to face this big surgery and to face the catabolic state after liver transplantation. So as much as possible, we would try to optimize the nutrition of the child, macronutrition as well as micronutrition. And we would monitor the child in view of mid-upper arm circumference and vitamin levels, because the weight might not be the best indicator in children with liver disease. So you have to go by mid-upper arm circumference. Exercise tolerance, we talk about frailty nowadays in transplant. So exercise tolerance is quite important. We encourage them to do exercise, especially for older children, and to do breathing exercises to tackle the difficult post-transplant period. Lastly, thrombophilia screen is not routinely performed. However, if it is a retransplant due to previous thrombosis or there is already occurring thrombosis, then we might do thrombophilia screen. So those are the assessments we would take a child and a family through during transplant assessment, and putting everything together, sorting out logistics. This will take good few weeks actually. Then coming to MDT referrals. It's very important that we have MDT culture and MDT team approach in liver transplantation. All the members are very, very important, and every member of the team would have a role to play. So starting from the transplant surgical team, we obviously get them involved since beginning and ask whether this is doable, what are the challenges, an anesthetic team, pediatric hepatology team, local consultant, local pediatrician, radiology, interventional radiology. It's very important that everybody is on page. Pathology department, where we'll be sending the explant of the liver, and maybe if we have problems with the transplanted liver, we'll be sending samples. So it's quite important to keep them informed and get their valuable inputs into place. Transfusion medicine, we have to have a word with them regarding blood products, antibody screening, and they really do help us in providing ROTEM as well as interpretation of the ROTEM following transplant to provide rational transfusion of blood products. Microbiology team, hematology, chemical pathology team, all are important to put a plan in place. Nutrition team is very important. We get a nutrition plan in place for the child till the transplant as well as following the transplant. Getting cardiac assessment and respiratory assessment whenever necessary and indicated. Cardiology assessment is mandatory actually, respiratory assessment whenever necessary. Child and adolescent psychiatry inputs. It's quite important. Liver transplantation is a difficult journey. It's a challenging journey to the little child as well as to the family. So we can't forget mental health. So child and adolescent psychiatry inputs are very, very crucial. Dental opinion, transplant coordinate, if that is in place, an ethics committee, especially when it comes to live donation. We can't just go and transplant. We need to submit all the documents of the donor and the recipient to ethics committee, and then they have to go through the documents and give us the approval. So all these team members would come into play. Social workers, especially in other countries, this is a very well established service to support children and families with their financial and social needs. And lastly, but very importantly, nursing and the supporting staff and all the other paramedical staff. I consider family as part of the MDT team because without their commitment, willingness, and they wanting to go through the transplant, there is no liver transplant happening. And they should be committed for this journey. So family is an important member of the MDT team. So now we have gone through various assessments, MDT referrals when we have identified a transplant candidate, and come into vaccinations. It's very important that the vaccination is up to date in a child who's going to go through a transplant. The principle is to delay a transplant for minimum of 4 weeks following live vaccine. and they are to be avoided after liver transplant, obviously due to the immunosuppression. So we use accelerated schedules to complete their vaccination as much as possible. And the beauty of live donor liver transplantation is we can plan a date and we can complete all these vaccinations well in advance. And at the same time, we check the antibody response for hepatitis B, A, varicella, and give booster doses if they are required, and extra vaccines as mentioned. The last part of the transplant assessment is counseling and family meetings. I'm sure we all would agree that children and families undergoing liver transplant would have complex medical and psychosocial needs. They are already compromised, anxious, and uncertain about their child's future. They would have a lot of questions, and sometimes they might not know what to ask, what not to ask. Despite of repeated meetings, it might be very challenging for them to absorb all this information as well, especially when it comes to technical details. So counseling and repeated family meetings are very, very important in liver transplant candidates and families. And consent and assent with adequate information is also important. We have this small booklet in our unit in Colombo North Center for Liver Diseases to provide some help for the families who need to understand the liver transplant journey. So going through all these assessments, MDT referrals, completing vaccination and counseling, we say the transplant assessment or the workup is done. Then what would be the next step? We would have an MDT meeting with all the members of the MDT team. And we would discuss this child in brief. And we would try to come to conclusions. Is liver transplant truly indicated? Is this doable in our setup? What are the challenges we anticipate in this particular child and the family? And what would be the proposed actions? And then we would design an individualized transplant protocol. So that is how the transplant assessment would end up. Though we plan a transplant and we do an assessment, it would not happen maybe the following day or in a week. Sometimes the children have to be on the transplant waiting list for some time, especially in the absence of suitable live donors, and they are waiting for a cadaveric donor. So it's very important that we closely monitor them, optimize them, update their details on the transplant waiting list, and getting in touch with the MDT team and update them, and ongoing psychosocial support. Meanwhile, we would further optimize nutrition, advise them to maintain good dental hygiene, meticulous management of complications related to chronic liver disease, because it's a shame if a child dies while being on transplant waiting list after going through all these four. The child would have a transplant, the family would be very hopeful, but while being on the waiting list, developed a complication and might succumb to death. So it's very important that we look after them carefully. And rational use of blood and blood products, the frequent children who are waiting liver transplant, the answer is no. There is no need for irradiated blood products, but rational use is very, very important. And making them psychologically ready for the cadaveric graft, kind of a transplant code. If it is not a live donor liver transplant, if it is a cadaveric donor liver transplant, we never know when would the date come. However, it might be quite challenging for a child and a family to get up in the middle of the night and pack their things up and come to the transplant unit to get the transplant. They might be quite anxious, might have a lot of mixed feelings. So it's very important to keep them ready for this transplant call. How are you going to find transport in the middle of the night? Will you have some savings of money to use at this occasion? Will you keep your things and records ready in a separate bag? All these things would come into play. Having discussed about the transplant assessment, I'll give you a brief idea about the types of liver grafts, because it's very important to know what are the types of liver grafts. We have cadaveric donors, which could be brain death or else after cardiac death. I'm not going into details. And it could be living donor liver transplant. Different countries have preferred programs, but most of the countries have both programs, one or the other predominating. The beauty of having a living donor liver transplant is you can perform the transplant in a more controlled situation. You can plan the date ahead, you can do vaccination, everything is preset. And the graft quality is obviously better compared to a deceased donor. And it could be full-size graft, reduced graft, or hyper-reduced graft. I'm not going into surgical details. Or a graft may be split into two, especially in a cadaveric scenario, to meet the requirements of two recipients sometimes. Auxiliary liver transplantation, again a novel modality of liver transplantation. Just to mention, you can have your own liver with the disease as well as the new liver. This is entertained especially in acute liver failure and metabolic scenarios. And hepatocyte transplantation is again a novel modality being investigated. So what are other factors which would be important to know when we consider about a live donation for a child needing a transplant? A person who's related or non-related can donate. It may be the mother, father, or it may be somebody who's totally non-related. However, blood group matching is required. Blood group matching is required. For example, a child having an A blood group and the child is having the liver disease, A blood group, a donor could be O or A, similar to that. However, this blood group matching is not really entertaining infants. The basis behind that decision is mainly because we think the immune system in infants is quite underdeveloped and they would not develop antibody-mediated rejection in infancy. So we do entertain mismatched transplants in infancy. And no HLA matching is required, it's just blood group matching. Donor factors, the age, BMI, comorbidity, especially diabetes, the alcohol history, whether they have metabolic associated fatty liver disease, prior history of tuberculosis, all these things would come into play when we do the donor assessment. Size and the body habitus might be looked into. And there are special occasions where we have to prioritize and use the grafts very carefully. If we have a family where all three children are affected with Wilson disease and only the mother meets the criteria for being a donor, then you, as the medical team, have got a challenge which child will require or which child would get this graft. Only one living donor is available in the family and you have three children waiting to be transplanted in the line. So there are special occasions you might have to consider, one for cadaveric and maybe for the other, you might consider live donation. COVID vaccination is very important. We encourage that for the donors because they are going to be in and out of the hospital. And psychology of the donor is quite important as well. So far I have discussed facts about pre-transplantation, how to identify a child needing transplant, what are the indications, contraindications, and when would we say yes, no, graft factors and donor factors. Now let's briefly look at the transplant surgery. I have included this part just to give you some context into liver transplantation in children. And I hope you will hear my video.
The following are the technical steps of a pediatric living donor liver transplant. To be procedure, the adult brought to separate operating rooms located next to each other and prepared for surgery. The living donation process starts with the removal of a section of the left lobe of the adult donor's liver. The size of the segment is determined by the size and weight of the recipient. The surgeon makes an upper midline incision from just below the xiphoid to just above the umbilicus. Once inside the abdomen, the surgeons will prepare the hepatic artery, portal vein, and the hepatic veins of the portion of liver to be used for transplantation. The designated section of the liver is then divided from the remainder of the liver with the blood vessels intact. The vessels to the portion of the liver to be used for transplantation are divided. The donor graft is handed to the recipient team, who flush the vessels with a preservative solution. The blood vessels on the donor side are closed with either sutures or a stapling device. The abdomen is closed. During the removal of the donor graft, a separate team of surgeons works to remove the recipient's liver in preparation for transplant. The blood supply and the bile duct are divided. First, the right and left branch of the hepatic artery are divided. Then the common hepatic and cystic ducts are divided. The portal vein is divided. A clamp is applied to the inferior vena cava, or IVC, below the liver. Another clamp is applied to the IVC above the liver. The hepatic veins are divided. And the diseased liver is removed. The prepared donor graft is brought into the recipient's OR room. The recipient's surgical team will reconnect all the major vessels and common bile duct, beginning with the hepatic vein. And then the portal vein. Flow is restored to the graft. The hepatic artery is connected, often using the operative microscope. Lastly, the bile duct is connected to a segment of bowel. The incision is closed and the patient transported to the ICU. The new liver will grow with the patient. Within 2 to 3 months, the donor's liver will have grown back to its original size.
So I hope that video was quite useful for you to understand what are the technical steps of the transplant surgery and give you some context into the topic we talked today. So now we shall move into post-transplant care. We have a child with liver disease. We have identified this child as a liver transplant candidate, and we have gone through transplant assessment, and hopefully now we have transplanted. So we would see how would the post-transplant period be. Post-transplant immediate care. It's very important that we understand the importance of immediate post-transplant management when we talk about the long-term outcome of a graft. Coming out of the surgery, the journey would not end because the graft survival, the long-term survival, all would depend on how you will look after this graft during the immediate and long-term post-transplant period. So basically 3 things I would say which would be really helpful: getting the people with necessary expertise, continuity of care throughout the immediate post-transplant period, and decision making in anticipation. Those are the 3 main things I think I would highlight, which would result in significantly good short-term and long-term outcomes. Having that in mind, we would look at what are the important key things we need to understand about a child in the immediate post-transplant period. Hemodynamics, graft function, as well as the infection risk. So hemodynamics is quite challenging because child must have had a lot of hiccups during the transplant surgery, especially it's quite challenging to the anesthetic team and the surgical team during the surgery. Sometimes things would happen which you would never anticipate. Hypothermia, circulatory collapses, bleeding, and they would put everything into place to survive the transplant surgery and bring the child to the intensive care. So it's very important to go back and look at the operative notes and anesthetic notes and understand what has happened during the surgery when you manage a child in the post-transplant period and when you assess the graft function. Infection risk is obviously there, especially in the context where you will put a child under immunosuppression after liver transplantation. In the Western world, in the developed countries, they have dedicated theaters and ICUs which would minimize this infectious risk. However, in a developing country, it would be challenging to have a dedicated theater, dedicated ICU only for liver transplant. So you might have children with pneumonia next to the transplanted child. You might have another disease next to the transplanted child. It may be COVID nowadays. So it's quite challenging to minimize the infection risk, but we have to be quite careful. Cover them with broad spectrum antibiotics, antifungals, and do not forget antivirals as well. Vascular and biliary complications. A commonly occurring complication is hepatic artery thrombosis. All would know, especially in these tiny babies, the anastomosis in these tiny vessels is quite challenging and they are more liable to get thrombosis. So vascular complications may occur. And biliary complications. Sometimes biliary leaks can occur even in the immediate transplant period. Rejection risk. The rejection risk starts actually after day 3, day 4 life. We forget about hyperacute rejection. We talk about the standard rejection we talk about in the post-transplant period. After day 3, day 4, you would expect the graft function to be normal, the liver functions to come back to normal, or at least to show declining trends. However, if they are going up again, then you have to think about rejection risk. Are we giving enough immunosuppression? You have to balance the rejection and infection risk in those circumstances. Blood products. It's very difficult to manage a child in the immediate post-transplant period without even a single blood product being transfused if we talk realistically. However, it's very important that we rationalize our blood products use with the help of the transfusion medicine as well as use of ROTEM. So targeted focused replacement with blood products is very important. Special protocols may exist to manage children with liver transplant following metabolic disease and combined transplant. So it's not the same protocol we use following a combined transplant, liver kidney, or following a metabolic disease for propionic acidemia. There are special protocols which we have to be aware of. And post-transplant period may be extra challenging in children with hepatopulmonary syndrome as well as portopulmonary hypertension. So we have to be prepared for long-term or prolonged use of oxygen in these children. Renoprotective measures. This is very important because following liver transplant, we know the child has to be on immunosuppression and that has to be lifelong immunosuppression. And one of the common agents we use is tacrolimus, which has a renal adverse effect profile. So we have to be very careful and minimize all the hits which would happen to the kidneys in the immediate post-transplant period. It could be pre-renal, renal, post-renal. So all these things would be considered when you're managing a child, because what we need is not the immediate survival. What we need is the long-term quality survival. So it's very important that you look at the renoprotective measures. Management setting, it's very important that we have a setup, a setting with strict isolation, less number of people visiting, with standard precautions when we're taking care of these children. Given the theoretical knowledge, it's very difficult and challenging in our setup where we really don't have places in place to care these children, especially with attached bathroom, but things would evolve with time. Psychological support to the child and family, very important. The trauma a child would go through during the transplantation process is enormous, and same for the family. And it's very important supporting them and keeping them informed throughout the process. And I will share this beautiful piece of work which was done by my team when we cared for the child during the post-transplant period. So we had a child who was transplanted, and we wanted to give this message, what happened to her and what is she going through and what would happen in the future in the nicest possible way. So our team came up with this bright idea where one of our house officers' sister was able to draw these nice pictures to show that child what happened to her. So this indicated what was she looking like initially, and then what happened to her liver. She went through the surgery and she recovered by the side of her mother, who was the donor to her. And now she's taking her meals and she feels happy, where we would expect her to achieve this world with full potential, with the new liver and the new life she has got. So this was a nice concept we used when we managed a child during the post-transplant period. Moving to post-transplant long-term care, it's very important that we look after the graft. Lifelong immunosuppression is a must. And balance between immunosuppression and infections, knowing about post-transplant lymphoproliferative disorder is very important, especially in our setup where the rate of infections are quite higher. Regular monitoring of graft function, compliance, and availability of medications. Very important that we should make sure the adequate medication stores are there for these children to take. A strong MDT relationship, the relationship with the anesthetic surgeon and the rest of the MDT team will never end. It will last throughout, and it is very important. And collaboration with the local team. And the local team, pediatricians are doing an excellent job in collaboration, looking after the children pre-transplant as well as post-transplant. So it's very important specialized units to collaborate with them. And we should give a health education and helpline whenever which is needed for the families. In case of an emergency, they should have a line to dial. And continuous psychological support. When it comes to long-term survival, it's very important that we talk about avoidance of alcohol, risk behavior, and lifestyle measures in these transplant candidates, because they will grow as adolescents and adults, and we should emphasize these things as well when they look after their grafts. Coming to medications, to give you a brief overview about medications, we know the immunosuppression will be lifelong, and we have different types of medications with different side effect profile. The key message is the lifelong immunosuppression is needed, and we have to be aware about the side effects. And they will need antimicrobial prophylaxis, antiplatelets, and anticoagulation medications, depending on their graft and the status which they had during the post-transplant period. And very important to be aware about the drug interactions, because some of the antibiotics, antifungals we use would have drug interactions with the tacrolimus and especially warfarin as well. So it's very important that we are aware about the drug interactions. To give you a brief idea about post-liver transplant complications, the rejection, acute, chronic, and sometimes it could be cell-mediated or antibody-mediated, infection risk, biliary complications, vascular complications, because we know the portal vein, hepatic arteriole needing anastomosis, those things can go into strictures, sometimes thrombosis, biliary leaks, biliary strictures. And it's very important to know about post-transplant lymphoproliferative disorder and the malignancies. There is a risk of malignancies. Recurrence of the disease is quite uncommon, but it could happen in autoimmune liver disease. And in a child who was transplanted for an indication which was not autoimmune, still they can have de novo autoimmune hepatitis. And sometimes special scenarios like BACP antibodies in PFIC type 2 and long-term drug-related complications. So these are the main complications we have to be aware when we look after a child in the post-transplant period. And all these factors would have an effect on the long-term graft survival. And monitoring a child post-transplant, when we see these children in the clinics as well as in the outpatient setup, we have to look at their graft status, growth, immunization, development, complications, as well as their compliance on drug levels. And whether they have returned to normality with good quality of life is also important. And during an intercurrent illness, it's very important that you touch base with the liver transplant unit and get the shared care and continue usual medications. Do not stop the immunosuppression and rational use of blood and blood products. And I would like to introduce this concept of liver transplant anniversary or transplant birthday review. Most of the countries and units practice this liver transplant anniversary or transplant birthday review at periodic intervals like 1 year, 5 year, and 10 years following transplant, where these things would help you to understand the graft status, their clinical status, biochemical status, and the histological status, especially because they could be asymptomatic with transaminitis. There may be histological involvement without transaminitis. So all these factors would be important in post-transplant management. So I have finished the bulk of the presentation and very briefly to touch on the current program challenges and the future. So I'll give you a brief idea about the evolution of pediatric liver transplantation in the world and in the country. This was the first pediatric liver transplant, which was performed in 1967 in Pittsburgh, USA, for a 2-year-old child with biliary atresia. And then they have talked about live donation in 1989. In the region, India did the first successful pediatric liver transplant in 2000. And then Sri Lanka performed the first adult liver transplant successfully, which was reported in 2010. And then the first successful pediatric liver transplantation in a child, pediatric liver transplantation took place last year, July, in a 9-year-old child weighing 17 kilograms who had progressive familial intrahepatic cholestasis type 3. Having that background, what was our data for the last year? So we had 22 children being identified as transplant candidates. 1 received the transplant in the unit and 1 had the transplant in India. 12 children are still awaiting to be transplanted and 8 children died without transplant. And all the children who died were less than 2 years and less than 10 kilos. COVID-19 pandemic had put a lot of threats into the transplant program, where there are travel restrictions, economical constraints, and donor availability, and the staff and patients are getting infected. All these factors came into play. So having understood about the program, what are the challenges and the way forward? So human resources and infrastructure still remains a challenge, especially for developing countries. That's why we have looked into development of the subspecialty of pediatric hepatology, gastroenterology, where we would get new knowledge into the country, and obviously improving infrastructure. All these factors would have an effect on good outcomes following liver transplant. And healthcare staff factors, awareness. We know there is some degree of awareness by looking at the number of referrals we had during the last year, and the positive attitude of the healthcare staff towards liver transplant. Whether the healthcare staff would discuss the option of transplant with the patients and families, would they consider that as a resort of management? The positive attitude is important, and the support of the healthcare staff, especially adapting a transplant program to existing general pediatric service, is quite challenging. It requires a lot of human resources as well as a lot of infrastructure. So the support is needed. And we need to build up on the MDT workforce to provide holistic care for these children. It's very important that we have all these members. Parents and families. We know there was positive attitude from families where they wanted to go to a neighboring country, spending a lot of money to get their children transplanted to offer this cure. So it was a positive attitude. And this man has lost 10 kilos to be a donor. for her child. So those are positive attitudes. However, it might not be really straightforward for a family, ordinary family who's coming from a rural area to make this transplant journey to a success. So we have to know the limitations, their needs, and cater these things. Lastly, coming to donor availability, in cadaveric donors, live donors, there are a lot of challenges, especially with the metabolic associated liver disease, where a lot of our parents are having either alcohol history, alcoholic liver disease, or they have diabetes or metabolic associated liver disease, fatty liver, where they simply can't donate to their children. So it's a problem. Actually, this has resulted in people going on social media asking for liver donors because none of the parents can donate for these children. So we have to prepare the donors and discuss about the donors quite early. Having all these challenges in place, is it still worth transplant? Positive stories, this lovely lady who had this photograph at the convocation where she was a transplant candidate, and this boy who won a lot of medals in the transplant games. Again, this young lady who's coming to visit her surgeon after 20 years, and this brave girl who received the transplant in Ragama last year. So looking at all these positive stories, we still feel it's worth transplanting. And backing the emotions with the current evidence and scientific literature, there are very good data about long-term good outcomes following liver transplantation. So this makes me to the end of the presentation. So I would like to highlight a few key messages. A significant disease burden exists in children needing liver transplant. There is no doubt about it. And liver transplant is actually not a novel therapy, it's the standard of care to prevent death and to improve quality of life. We really need to build up on the resources, infrastructure, and the positive attitude towards liver transplantation. And we should start the conversation early. Timely referral is quite crucial to get the optimum benefits of the existing program, especially when we try to manage our logistics in a developing program. The time matters. So timely referral is very, very important for us to provide best care for the children and families. Thank you so much for your patient listening.
Thank you so much, Dr. Meghanti, for that excellent lecture. So before we move to our discussion, I'd like to kindly remind our audience to fill the feedback form for which I have shared the link in the chat box.